you too.
Oh,
I
okay,
kind of
now.
figured you'll be here.
Yeah. All right. Let's see. Hit okay. All right. And should we wait just a little bit longer here?
Yeah, I'd say give till 12:03 just in case a couple more people are going to hop on.
Okay. Lauren, thanks for sharing in your across the art community. And DDI also shared it, I think, because of you. So thank you.
Okay, good.
Again, Jamelia will be joining us when she can. Yeah, she's balancing a number of things today.
Yes, aren't we all?
All right. Well, I think we're going to go ahead and get started. I want to welcome those of you that are here and those that are listening to the recording to today's discussion on medication management for patients with intellectual and developmental disabilities. My name is Steve Erickson. I'm an associate professor here at the College of Pharmacy at the University of Michigan and a member of the center. And at the moment, I'm going to go share my slides here. And get it in presentation mode. All right, can those of you see
Yes.
the slides good? All right. So again, thanks for joining us today. Talk about a really important issue that I think is under the radar for a lot of clinicians, and those are the folks with intellectual disability and their medications. And so today we have three speakers. Dr. Jamelia Aladimi from the University of Cincinnati. She's an ambulatory care clinical pharmacist, and she'll be joining us in a little bit. Also with us is Dr. Mark Schneiderhan, who's an associate professor at the University of Minnesota, practicing in psychiatry. The three of us, I'll let each of us kind of introduce ourselves as we go through our individual sections. Today, what we'll do is we're going to describe the characteristics of medication management for persons with intellectual and developmental disability. We're going to describe the unique aspects of medication management and associated outcomes for people with intellectual and developmental disability, and describe benefits of medication management overseen by pharmacists in the clinic and in the home setting for this patient population. And I'll use probably the abbreviation IDD throughout the presentation to refer to folks with intellectual and developmental disability. So a little bit of background first before we dive into our specific disciplines and practices. People with intellectual disability are characterized by individuals that have significant limitations in intellectual functioning and adaptive behavior. And this occurs before the age of 22. So often you're born with a condition associated with IDD or acquire it in childhood and adolescence. The term developmental disability is a very broad category, could include intellectual, physical, or both impairments in the individual. Some examples include people who are autistic or who have autism spectrum disorder, people who have a brain injury, either at birth or during childhood or adolescence, cerebral palsy, people with Down syndrome, fetal alcohol syndrome, spina bifida, and there's the catch-all of intellectual disability of unknown reason. Yeah, a little bit dated is the number of folks, but in 2016, a population-based study demonstrated, about over 7 million people in the United States can be categorized or have an intellectual or developmental disability. So we're talking about a significant number of people, honestly, that are in our population and in our medical practices and pharmacy settings that we work with. What's important to realize that people with IDD are living longer than ever before. And a great example are people with Down syndrome. In 1983, the mean age of death was around 25 years of age. A lot of that had to do with childhood leukemias, cardiac malformations that were present at birth. Many of these are addressed now and screened for and addressed in pediatrics. And so folks are living to not the age of the similar general population, but much longer. In Down syndrome, the average age of death is 58. But they're living a lot longer than they used to. And with that comes chronic illnesses. Chronic illnesses that the general population experience, including hypertension, diabetes, arthritis, and asthma, but also other condition related illnesses or diagnoses such as seizure disorder, sensory impairment with hearing and vision, GI with constipation and gastroesophageal reflux, hypothyroidism, dementia. There's just to name a few of the conditions that are probably more common in the population than the general population. Of course, with more illness comes more medications, and that's where we come in as far as the understanding the role of having an IDD and the problems associated with medications. Here's an example of a general medicine practice here, a study we did a number of years ago within our general medicine practice. Again, highlighting some of the conditions that we see more often in our patient population with ID, hypothyroidism, interesting skin and toenail fungus infections, which is pretty common in this population. Fluid and electrolyte imbalance has to do with heart failure, more common, paralysis, underweight, not only obesity, but also underweight population. Seizure disorder, much more common. And mental illness is documented as more common, including behaviors that challenge. Now, again, when we talk about more illness, we talk about medications. And we know that medication management is complex for anybody. But folks with intellectual disability and their support network often find challenges in managing medicines. As we know, it's a complex process. It starts with meeting with the clinician and having a medication prescribed. That communication right there can lead to a lot of discrepancies and disparities in prescribing the appropriate treatment and understanding the treatment when you go home. Prescribing, going home, storing it, getting the medicine from the pharmacy can be challenging in itself with prior authorizations and other policy related issues, and just accessing the pharmacy. Going home and administering the medicines correctly and monitoring and evaluating, all of these lead to a complex process that folks with IDD have difficulty with. So we break it down and what are the needs of the person with the disability? What are the needs of the healthcare provider, their education, their understanding, the time that's required to work with folks with IDD? That of the caregiver. Can't stress enough the importance of a caregiver, whether it's family and or employed caregiver, such as direct support staff, in helping to manage medications for folks with IDD. And importantly, what does the health system need to improve their care for patients overall, including in the in medication prescribing and utilizations? Now, I just want to point out here and take a second here. I have this great model here. This is my son, Christopher. He's a 35-year-old young man. He has Down syndrome. And he's why I've spent the last 20 years working in this area. But I also use this picture to highlight the need to understand the role of the caregiver. This is one of his favorite caregivers he works with. And again, her level and needs of of understanding drug therapy for not only him, but the other folks that she works with is crucial to have success, safe and effective use of medications. I want to go through a few slides here describing some of the challenges that are present that we find in the literature, some of the work that I've done and others around med management. So first of all, folks with intellectual disability and IDD are subject to polypharmacy. There's a number of reasons for that. More chronic illnesses, but also more psychiatric diagnoses, and the behaviors that challenge tend to be a little more present in the population. And what does that lead to? It leads to more and more medications. This particular study is one that we did in our population, but is similar to all the data from the last 20 years in the literature, that polypharmacy or having many medications is common in this population. For example, people with 10 or more medications, 55% of the sample in our general medicine population were on 10 or more medications. That includes as needed medicines, but still, nonetheless, that's a lot of meds. A lot of medications lead to drug interactions. And this is a study I did with colleagues from Minnesota and from Oklahoma, where we looked at a data set called National Core Indicators. And we basically identified that on average, the person on medication, a person with IDD on these medication regimens have about 8 potential drug interactions. Now, these are potential. When we look at those truly clinically significant, it's kind of low, but still it's higher than the national average for people without IDD. A lot of that has to do with polypharmacy and the type of medicines that are prescribed. These medication regimens are complex. Folks with IDD are often have inhaled medications, medications in the ears and the eyes, in other parts of their body, the liquids that have to be measured out. These are complex medication regimens taken multiple times per day. And in a study we did here, again, in our general medicine population, we used a kind of a standardized instrument called the Medication Regimen Complexity Index and demonstrated that our general medicine patients with intellectual disability had a score of 29 compared to 16 on the regimen complexity index scale for age similar folks without IDD. What does that mean? It means that these folks with IDD have very complex regimens that they and caregivers have to manage. And so that's a point I want to make, that caregivers have to learn how to manage these different medications along with the person they're caring for. And this is an important point. Comparing this number here of 29 to the literature studies in the geriatric population using the same index have found that scores this high are associated with a greater risk of hospitalization for an adverse medication event. So again, another risk factor. We also find that health literacy, folks with IDD often don't understand their medicines or have a very minimal understanding of their therapy. That then leads to what is the health literacy of the caregivers? In a study we did, we found that caregivers' health literacy is varied and wide, just like the general population, but you know what? They're taking care of someone else. So we would hope that they have a high health literacy. We studied it and compared it to their likelihood of making errors based on what's called the medication administration test. And as you might guess, high health literacy, you had a lower likelihood of causing med errors. This again is a potentially significant issue in especially in our group home and supported living environments. That direct support professional and the family both have, in a study that we did a few years ago across the state of Michigan, from Detroit to Oscoda, on over to Lansing and Grand Rapids, and we've talked to caregivers, both family and direct support staff, and said, what are your issues with medication management? And they said, number one are the prescribers. Part of that is poor communication with the caregiver and with the patient themselves, but also things like accuracy of the medication record. My gosh, that's something I'm always running against. Between the mental health system and the physical health system, those records often are disparate, inaccurate, and contradictory in some cases, which leads to a big problem. We also find patients' willingness to take the medicines. Patients have the right to refuse. People with IDD have the right to refuse their medications. So it takes a savvy caregiver, someone who's worked with that person for a long time, to really often understand how to get folks to take their medicines. And In a system where there's a high turnover of caregivers, especially in group home and supported environments, that can be a problem. And also, this highlighted the health system is unprepared to work with people with IDD. Caregivers often have a lot of anxiety associated with managing medications, especially employed caregivers or direct support staff, often because they're fairly new and don't know the patient or the client or the medications that they're on. They often lack a lot of in-depth training, and the person they're supporting often requires a lot of help, and this can be overwhelming to the caregiver. Another study, we looked at caregivers' knowledge and understanding of asthma, just to get the idea of what their beliefs and attitudes and understanding of asthma and how that might impact the person they're caring for. And we found that, caregivers often, when they're caring for a person with asthma, that they don't know what those triggers are. Now, good inhaler technique, knowledge of the medication. This study found that of people with IDD and asthma, most of them were not well controlled and they were not adherent to therapy. We found in this project that caregivers' beliefs and attitudes about those medications directly was associated with, will that person get their medication? A couple more slides here. Adverse medication events. We conducted a study using what's called AHEAD-DC. It's a nationally representative study a few years ago of ER and hospitalization visits, and we found that folks with intellectual disability are significantly more likely to be hospitalized for an adverse medication event compared to the general population. And also, we found in another study using what's called Optum or Clin Informatics data set of 10 million people, we asked the question, are folks with intellectual disability and heart failure or folks with IDD and heart disease, are they getting the guideline-based therapies that they should be getting based on their illness? And we find that there's just significant disparities there, that the folks with IDD and heart disease or heart failure are not getting these guideline-based therapy compared to the general population. And folks with Down syndrome, the lowest likelihood of getting these medications. So, to wrap up my part of this section here, I hope I impressed upon you that folks with intellectual and developmental disability need help. They need help from our prescribers, they need help from our pharmacists, they need help from the caregivers that are helping to manage their medications. And one of the interventions, if you will, that's successful is having a pharmacist more involved in their care. So let's see. At this point, Jamelia, are you on?
No, she's not on.
Not yet. Okay. Well, then let's have Mark take over at this point. All right. And Mark, are you able to share your slides, do you think?
Oh, sure.
Or do
I
you
don't
want me
have
to?
the same, I didn't have the same slide set. Mine is black and white. Is that okay? Or you can go with yours. I can tell
Yeah.
you when to advance if
Yeah.
you have everything.
Okay. We could do that. Yeah.
So, yes, hi everyone. My name is Mark Schneiderhan. I'm an associate professor at the College of Pharmacy and at the University of Minnesota. I am also a clinician at the Human Development Center. Actually, that's where I'm at right now at this moment. I'm in my office at the clinic. So, yeah, I'm glad to be here. And thanks, Dr. Erickson. Thanks for inviting me to join this panel. So, and you can advance the slide to the next one. Thank you. So just about me, you can like breathe. I'm not going to spend a lot of time, but I'm a dad, and that's a big deal for me. And so, my teaching goals are to advance the practice of pharmacists providing comprehensive medication management services, which I'll talk about. And it's really, I'm really just, I'm the son of a pharmacist, and I just really, really enjoy what I do. And I'll tell you a little bit more about that. Next slide. So if we can go to the next slide, what I'd like to do is talk about comprehensive medication management and the role of the psychiatric pharmacist. Okay, next slide. And some of the key things that I want to talk about, and I'm going to probably impress this over and over again, is the collaborative nature of my practice. I'm not a solo practitioner by any means, and in fact, I meet monthly with the psychiatry team. I have a person who attending psychiatrist who I meet with, and also I'm very close with the nurse practitioners too, as well. And is the slides advancing or no? I mean, I don't know if they are.
Yep. Yep. Now we're on how psychiatric pharmacists care for patients.
Okay, I'm not seeing that on my end.
Yeah,
So
we still see the comprehensive medication management slide. Maybe if you unshare and reshare, it seems like
Okay.
it froze.
Let's do that.
Okay.
Let's see.
I was kind of winging it as much as I could from memory.
All right, here we go. All right, so you still with me?
Yep.
All right,
Thanks.
I'm going to put you over here. Sorry about that.
Oh, you're okay.
Let me share there, and
There you go.
there you go.
All right. So this is basically talking about collaboration with providers, and also referring the patient. So I'm in a closed system. We just provide. We're in a community mental health clinic, and so we don't have primary care services, and so everything I need to get is through either getting a release of information and trying to get information across disciplines, because my patients are usually seen by other prescribers as well. So I do have a panel of about 70 patients that I see. And then I'm a consultant within the clinic. So my other prescribers in the clinic, the nurse practitioners and the psychiatrists, refer patients who have complex medication challenges, or, and a lot of my patients actually are in adult foster care. They may have intellectual developmental disabilities. And also, if you can go to the next slide, this is the clinic, and I'll talk a little bit more about that. This is the Human Development Center logo. Go to the next slide. So I'm located in Northeast Minnesota, so right on the shores of Lake Superior, and we cover a pretty broad area of patients. And I see patients in Duluth. It's a small city of about 80,000 people, and then our twin city is in Wisconsin, in Douglas County, in Superior, Wisconsin. So I have patients that I see over there. I'm also part of an ACT team, a assertive community treatment team as well. Next slide. So you can see some of the areas that I work in: psychiatry, assertive community treatment. TACT is transitional, more younger people with more substance use disorders as well. So next slide. This is my team. You can see that we have nursing, we have and nurse practitioners and psychiatrists as part of our team. So next slide. So I have under a collaborative practice agreement, so I can prescribe medications, make changes based on target symptoms. I don't diagnose. My patients come in with they've been worked up with a psych eval, and then my evaluation is a comprehensive medication management. And I tell my patients I'm doing a deep dive into their medications. I'm trying to make sure that their medications are the right medication for the right indication at the right dose, that the person is tolerating these medications, that they're convenient, and sometimes sometimes there might be times where they're having symptoms that are untreated. So I'm looking for untreated symptoms. I'm looking for problems like medications that are maybe not being monitored. So I do a lot of monitoring of these medications as a preventative means for preventing side effects and kind of heading off any potential problems, because the medications in psychiatry just come along with a lot of side effects. And I made a whole practice of managing side effects since I've been doing this since the mid-90s. There has been so many changes in medications between 95 and mid-2000. But there has been very little in the advancement of psychiatric medications until recently. We're starting to see some more advancement in psychiatric medications, but they're very expensive, especially the new medications that are newly approved. So, but I'm very interested in looking at that. One of my goals of therapy for most of my patients with IDD are to really look at how can I reduce medications and find the lowest effective dose, and also make sure that they're connected with their primary care. So every patient I ask, like, when is your next primary care appointment? I also look at when they had their labs, because some of the treatments that we use, especially the antipsychotic therapies, cause a higher risk for diabetes, hypertension, dyslipidemia. And those are things that I cannot manage based on my collaborative practice agreement. And I have to actually, if I detect anything, then I have to refer those patients out for additional assessment and treatment. So if labs come back abnormal, then it's my responsibility to make sure that they're connected, and also communicating with their primary care. I also work with guardians, and I like having the guardian in the room with me. I often invite the guardian to either be on phone or video or in person. So I do a lot of in person. Most of my visits are in person in my office. So I usually have caregivers or staff from the adult foster care homes in the room with me, and I usually I actually ask for behavioral records. I sometimes don't get them, and so I have to. So if you go to the next slide, I can tell you a little bit about how my practice is laid out. So I have an RN who's assigned to me every day that I'm in clinic, and I'm at 40% of my time is in clinic. I'm teaching also at the College of Pharmacy. I have students, but my RN will get a weight, vitals, and room my patient, and then I'll make sure that all the release of informations are signed. This week, I had a patient who had a guardian who was at the county level, and we had to fax release of information out to allow me to do pharmacogenomic testing, because the patient was not doing well on medications, coming in with a lot of side effects such as tremor, and so we were trying to look at future treatment, and also making sure that what they were on, that was the best medication, that it was being metabolized correctly, or at least normally metabolized, because the pharmacogenomic testing can help maybe give me some information around whether the dose is too high or too low, and also maybe making future recommendations. So that was just one thing that I've been getting a lot of referrals from our advanced practice nurses. So when I see a patient, I'm doing like a side effect assessment. I'm looking at adherence. I'm reviewing the medication list, and also comparing it with medications that the patient that we are prescribing as well, to make sure that they all line up. Like Dr. Erickson mentioned, that sometimes there's disconnections between, even at the home level and in our clinic, and then trying to get all those tied together is a big deal. So if you go to the next slide. So I'm going to hold off here and get Jamelia in, and if we have time, we can go over a case, if that makes sense.
Sure.
Dr. Erickson, what do you think?
That sounds good. That sounds good. All right, Jamelia.
Hi, everyone. Sorry,
Make everyone busy here. There you go.
yeah. Hi, sorry, I'm late to join the party. But I'm happy to participate in this panel discussion today. I think we have some great discussion surrounding this topic. I'll start with a little bit about myself and my role here at UC Health. So my name is Jamila. I am a clinical pharmacist. I practice in primary care. I've been a pharmacist for about 10 years now. And I knew I wanted to do my practice as a pharmacist in a way that made an impact to patients. So I started early on in my career pursuing an embedded model where I get to be in the actual primary care office and work directly with physicians and providers and the patients. Currently, I practice at UC Health. I provide services for 3 going on 2 clinics. One of them which is the Freeman Center for patients with intellectual and developmental disabilities. So next slide, please. A little bit about what I do as a clinical pharmacist at UC Health and our model here. So we're a little bit about a 4-hour drive from Michigan area. Cincinnati is close to the border of Kentucky. Just to give everyone some background of UC Health and where we're located. But our team recently grew a lot in terms of our clinical pharmacy in the outpatient care, or providing integrated services within our primary care offices. So what does our model look like? We have scheduled visits, but we also do a lot of on-demand services in the office. So medication reconciliation, drug information questions as they come up. If I'm not physically in the office, I'm available via Epic Chat for providers. And oftentimes we follow up on things after the appointment, since it's not always conducive during the visit, but when needed, sometimes we'll do like a curbside consult when the patients are there, because that's the best time to sometimes do a warm handoff, make that connection. We do a lot of our visits over the phone. So physicians will often refer to us via collaborative practice agreement, so they can put in a referral to pharmacy. I do a lot of disease state management for diabetes, also hypertension. Primarily diabetes, I would say, because there's a lot that goes into managing diabetes, as we all know. We do a lot with setting up continuous glucose monitors, insulin titration, and really working through those barriers patients have with self-management, which is actually one of my greatest passions as a pharmacist, having type 1 diabetes myself for over 20 years now. So those are our 2 primary chronic disease states that we manage. We are looking to expand into other areas, but that's where we're finding there's the greatest need. We also do consults with the providers and the patient. So for example, patient sends a drug question to their doctor. Doctor will forward it to me, and I'll reach out to the patient, discuss the side effects they're having, if there's something we can do to manage those side effects, maybe we're taking it incorrectly. A lot of polypharmacy consults. So this is something that I would say is more heavily on the Freeman Center's office, but both offices we see polypharmacy, whether that be using multiple pharmacies or being on multiple medications, and maybe there's opportunities to deprescribe or talk with the patient, see what, if any of them are leading or contributing to their problem that they might be experiencing. And then the other thing, lab follow-up and drug adjustments. That usually is following up on TSH and potassium, I would say is the most common lab follow-up. I do a few INRs. Most of them go to our anticoagulation clinic. So TSH is a big one because that involves a lot of potential medication interactions, the particular administration with it being on an empty stomach. So assessing for those before we make a dose adjustment. In the state of Ohio, we can practice under a CPA or collaborative practice agreement. So that's what we're using here at UC Health. Also, it's important to note that when I go into an office, it's about building the relationship with the providers first and letting them know about the CPA so that they feel comfortable. And every provider uses me in different ways. One provider I know, like anytime the A1C is above goal, they'll typically refer, whereas some will only refer when there's insulin titration involved. And some like to manage it all. It's fine. Everyone is different, and I work with different patients and providers and meeting them where they're at. Next slide. I want to highlight the Freeman Center, of course. This is something we're all passionate and excited about here at UC Health. It is named in honor of Dr. Timothy Freeman and his service to individuals with disabilities. He has spent his practice kind of dedicating his life to servicing these patients and really building up a panel of patients with disabilities and fighting and advocating for them. His life mission was to have a dedicated center. Unfortunately, in February of 2021, he was diagnosed with aggressive form of stomach cancer and passed away shortly after. And it wasn't until after his passing that the Freeman Center was able to really truly come into fruition and get a lot of grant funding. And we were able to grow significantly in the last few years. And that's where I fortunately was able to get the position at UC and become integral to helping our patients here. We provide care for adults 18 years and older. And one of the things that's unique about the Freeman Center is the mission is to be like a one-stop shop. So our patients can get primary, also behavior health care in one setting. We have psych doctors and clinical therapists that see our patients in the Freeman Center. And we're moving to a new building in September. So more to come on that, but with the new building, the vision is to also have a pharmacy, eventually dental care, and be able to provide everything there for our patients. Right now, it's kind of hard because it's essentially 2 offices in one location, but there's a lot of growth that's happening. All right, next slide. A little bit about what I do at the Freeman Center specifically. So it's essentially the disease state management via collaborative practice, similar to what I would at any office. Of course, it looks a little bit different with our patient population at the Freeman Center. A big thing with the Freeman Center is medication review and reconciliation. This is important with all the different transitions of care and care providers, caregivers that patients often have. Oftentimes non-medical care providers or people working with the patients, I should say, that need explicit instructions and require a different level of detail and education for safe use of the medication. Medication access needs, our patients do have unique needs. Oftentimes that looks like needing a liquid formulation or a particular formulation of a drug. And insurance isn't approving. So working through a lot of those barriers. And then of course the drug information consults that come up from providers and often patients as well. Next slide, please. And I think this is the theme of our discussion today, just going over some of the unique drug therapy needs to patients with disabilities. I already touched upon the medication reconciliation. I've worked in doing medication reconciliations, or MedRec for short, a lot. But I think it takes on a different form in this setting, because we have multiple care providers, different pharmacies being used sometimes, and then of course the use of pill packs. So typically we think of pill packs as being a good adherence tool, which it is, but it also creates problems if we need to make changes to the regimen, as we order the change, but then they still have the old dosage in their pill pack, and it really requires skill to find that medication, remove it, put in the new one, and also coordination with who's filling the pill pack. So oftentimes what we're noticing, or what I noticed when I first started coming here, is meds that were discontinued were still being taken. Also electronic issues. The pharmacy that we use primarily, who does our pill packaging, wasn't getting our discontinuations in our system. So of course that led to a lot of problems. And oftentimes MedRec for just one medication, warfarin of course comes to mind, but that can be any medication, can be hard to figure out. When did it first get stopped? Are we still taking it? What dose are we taking? So really sorting through that and determining what the patient is actually taking at home. Medication administration challenges is huge in this patient population. We see a lot of swallowing difficulties, sensory sensitivities, behavioral resistance, and unique needs when it comes to enteral tube feeds. So that's one thing. I get a lot of crush consults, like, can this be crushed? They're using a G tube or an NG tube. So figuring out what can be taken safely and making sure that the care provider, caregiver is well equipped to do so. With the sensory sensitivities and behavioral resistance, that is how our collaborative practice agreement, if we're doing a disease state management, can take on some unique challenges. So for example, in working with patients who have diabetes and also IDD, we often have to come up with some unique strategies or different ways of going about providing care if there's resistance to taking an injection when they really need an injection. So meeting with the families and coming up with ways to do that, especially if they're going to be resistant or need to have it be done. So one example is with using weekly GLP-1s. We determined that the patient just would not get it from mom. So we had to come up with a way where either originally it started off with me giving the injection, but then finding a nurse that could give it at his day program once a week. And then of course, anytime there is a medication adjustment, the staff needs to be aware. It's not just, okay, increase this dose, I'm sending it in. It's also making sure that the staff has that in writing and taking the extra steps to make sure we're sending that to the appropriate care provider. The other thing we noticed differently in patients with IDD is different pharmacodynamic or kinetic variations. So the comorbidities, of course, create different needs. Often our patients have metabolic syndrome, altered metabolism, and in Down syndrome, it can be common to have different drug metabolism, and then more sensitivity to side effects. Caregiver dependency. So often, of course, we're talking to a care provider or a caregiver instead of the patient itself, which creates unique challenges in determining if the medication is working, what side effects are we experiencing from the medication? Is it a medication side effect, or could it be something else? So assessing drug therapy takes on a different form, of course, in these patients. And then, as I talked about before, the medication access and coverage can be a particular hurdle for our families. So helping patients with that. I did an appeal recently for a patient with Down syndrome and obstructive sleep apnea who has who also has obesity and needs to lose weight. Insurance denied the Zepbound, but after doing an appeal explaining the need there, we were able to get that covered. So taking those steps there to help our patients access the drugs that they need. All right, and I think that's all I have for my portion. So does anyone have any particular questions about the slides I presented?
I just wish we had a Freedman Center in Michigan somewhere, because I think one of the deterrents for people, or for agencies or practices to deal with people's IDD, is the time it takes to interact with them and the amount of reimbursement, because like 99% of our people are Medicare, Medicaid, primary Medicaid, and has a lower rate of reimbursement than other insurance. So that time and rate of reimbursement, I think that's a big deterrent to helping people with IDD, especially the time, but they have my behavioral resistance and and swallowing difficulties. Sometimes, we have some people, particularly people with Down syndrome or ASD, that may have some swallowing difficulties that need a liquid medication, and getting that to change over to a liquid medication sometimes is a challenge, even if finding that medication in liquid form could be a challenge sometimes. So sometimes they crunch it up, put it in peanut butter or something, and try to give it that way. But I think that's a difficulty. So a lot of our people live in group homes and are in Michigan. They have a pretty extensive training, and it's mostly on not missing a medication dose. That's the biggest part of the training, and counting the medications. So at each shift, the medications are counted, one by one, to make sure there's some missed dosage. Or if a patient goes out and the time limit for him, because he might miss a dose. Like, give example, we have Special Olympics basketball, and sometimes those tournaments last, we'll be at a different site the whole day. And if they win, we might be in like an overnight type situation. So their medications, who's going to give them their medications? Because a lot of times the group home staff doesn't go with us on the trip to from Detroit to Grand Rapids. And that's the overnight. Then we have another group that's overseas. And we have Athletes Without Limits. They play internationally. And this group, like, we're going to be in Astana, Kazakhstan from June 8th to June probably 16th. But that population, none of them, one guy is on medication. And his caregiver, which is his mother, she travels with him. So other than that, so he should be he should be okay.
Yeah, that's what, as is Steve, that's one of the things that, as a chaperone for Special Olympics myself and a coach, that's one of the things that we often struggle with is the medication management.
Right.
And
right.
we brought that up with Special Olympics. That's something that down the road they're talking about looking at again. So, yeah. Awesome. But thank you, Mr. Glover, for real world experience here from the advocate side here. I'm going to wrap up with this next section here, talking about yet another opportunity for pharmacists to be involved. And actually, it's a takeoff, Mr. Glover, from your comments about where folks live in the community and the group home setting, and the potential problems with that. And so realizing that pharmacists have a potential role in folks living in these supported environments. I've conducted a couple different projects and then developed a practice here at University of Michigan, kind of focused on folks in group homes. Are you able to see the slide here which says in-home comprehensive med reviews?
Yeah.
Yes, we can see it.
All right. So just a quick background, I worked with a local supports agency in the Wayne County area a number of years ago to do this pilot study where the pharmacist would, where the agency, supports agency, identified folks on with multiple medications and would send me a list. We would get the approval from the individual as well as their legal guardian or their power of attorney, um, shared guardianship. But what we would do is we'd identify these folks and I would do a home visit. So I would prepare ahead of time with as much information as I had. I didn't have access to medical records, but I would go to the home, and within the home, there's a lot of information. There is the medication book, including paper copies of the scripts. There are vital signs, there are a history, there are notes from the doctor's office and so forth. So there's a lot of information that is available, but yet we're missing things like blood levels and lab reports and that sort of thing. But it was from a feasibility study, it demonstrated that pharmacists could actually go into the home and conduct these. That usually took about a half-hour prep time, including driving, another hour or so per person within the home, meeting with the patient and the staff, and then another hour or so of diving through and identifying issues and contacting prescribers when necessary. And in this particular project, I approached it as if I was in a long-term care. I used to be a consultant pharmacist in long-term care, and this was the kind of the approach I took as well as in the clinic setting that I worked in general medicine. I found an average of about 2.5 med-related problems per person by being in the home. So no indication for use of medications, identifying a medical problem that wasn't treated. The toenail fungus was one of them that we identified, but other problems. Just a real quick example. There was a person who was having diarrhea to the point where a staff member quit because of having to clean the individual. And I sat down and went through the meds, and they had recently been started on metformin for diabetes management. And the person was having an adverse effect to with the diarrhea to the metformin. We had the dose, and they started on a high dose, so we were able to lower the dose. The diarrhea went away, and the patient was happy. We found other issues with wrong dosage forms being used or given. Crushing extended release tablets is a no-no. Duplications of error medications. I just want to highlight one problem that we also identified. There was a person who had, when I sat down, I actually looked at their prescriptions and I saw there was a liquid seizure medicine that they were taking. And previously they had a tablet for the same type of medicine. This person had been recently discharged from a hospital with a fall where she had fractures. And this had occurred, it turns out that the person had developed swallowing problems. And so they were prescribing a liquid form of the medicine, but the prescriber didn't understand the conversion and doubled the dose. And they didn't catch it in the home either. So this person for about 2 weeks was being overdosed on this medication. It wasn't, and then they were in the hospital and then they went back home on that same regimen. So when I was doing in the home, I actually had everything together. I could say, aha, we got a problem here. They're being overdosed with this liquid. So we got them on the right medication. That's the kind of thing that when you get in the home and see what's going on in the home environment, that you can identify things. One more thing about this is you can identify things like potential waste where, and it was mentioned earlier by Jamila, and that is, for example, meds that have been discontinued are still showing up, or as needed medicines are being sent regularly. 5 inhalers for one patient at $100 plus per inhaler sitting there because there was miscommunication in a drug being changed and whether they need it or not. So there's great opportunities, I think, here from the clinic setting to the in-home setting that pharmacists can add value to improving the safe and effective use of medications. I just wanted to cover a couple more aspects before we wrap up here, and that is there are guidelines out there to help clinicians in managing chronic illness and mental illness in individuals. So first of all, the 2018 Canadian guidelines are a wonderful source of information on things that primary care providers should look for in working with their patients with IDD, and especially around the prescribing of different medications. I love this quote here in another publication that addressed the guidelines: allow pharmacists to conduct full scope of practice, including collaboratives, of which you've just seen and heard here with our two other guests. There are other guidelines, the adult Down syndrome guidelines published in JAMA a few years ago, also found at this website here. And I can't stress enough the Vanderbilt Healthcare for Adults with IDD Toolkit, a wonderful resource to go to for identifying those more common issues in folks with IDD and how to manage them. As far as psychotropic drug prescribing, there are initiatives. The UK has an interesting one called the STOMP initiative to stop over-medicating folks with IDD. We also have the OPTI-ID, which is another one. And here in the United States, at University of New Hampshire, we have the Integrated Mental Health Treatment Guidelines for Dr. Beasley. These are guidelines that are very helpful. I see Mark has his hand up.
Actually, Andy had a question. There was a question in the audience. I was going to give her some
Absolutely.
airtime when you get a chance. That's
Yeah.
what I wanted to.
Thanks. I just want to wrap up with, again, this handsome guy here, Christopher, saying healthcare providers have an obligation to assure the safe and effective use of medicines with disabilities. And if we're all on the same page and working together, people are happy. And it doesn't take a cheeseburger to make you happy. It's just, all right. Before we get to the question, though, I do want to thank a couple people, Andy Afoy and Andy Brogies. Again, Brocious, I thank you very much for your help in organizing and putting this together. And then Doctors Michelle Mead and Mike McKee, who are the leaders of our center. Without them, the center wouldn't have existed. So their vision and energy to keep us going here at the University of Michigan has been essential for moving things ahead. All right, so time for some of the questions.
Yeah, do you or any of the doctors here have recommendations for helping patients who have behavioral resistance to taking meds? And I think like sometimes that can be a psychological issue, or sometimes it's more a sensory issue. But if a patient is very averse to taking a med they need to take, are there good recommendations?
So could I maybe just make sure I got the question right, if that's okay?
Yeah.
I'd like to, because I see a lot of patients with behavioral, they come to me mostly with on medications to address behavioral problems and especially self-injurious behaviors or striking out at other people, or sometimes it could be other disruptive behaviors as well. And so the question is about patients who have sensitivities around medications and maybe resistant, or maybe just like they've tried different medications and they haven't had good success. Maybe they had adverse effects. Maybe they've tried different meds and basically the side effects were just intolerable. Is that kind of what you're getting at, Andy? Is that the type?
I was more getting at like just a resistance to actually taking a med, swallowing a pill. Like they just don't want to take a needed medication.
Okay, so they just won't like take it at all because of sensory, because it's hard to swallow, or it doesn't taste well, doesn't taste good, or they might not understand why they're even taking it, right?
Yeah, or even just demand avoidance. They just don't simply don't want to.
Yeah. If it's really needed, and sometimes there's different formulations that sometimes I prescribe. There's dissolving formulations that it just has to go on their tongue, and it has a minty taste and can just be dissolved. There's some administration people need, like sometimes I've worked with people around patches too, transdermal patches, and they can be applied in different areas where they can't reach, and then they, we just have to watch. They have to move the patch around, and that way there's different ways to get around the oral. There's some, we don't necessarily need to jump to it, but sometimes I do have a number of patients on long-acting injectable medications, and I actually had a practice that I administered those medications and monitored those medications. And patients, sometimes they may have absorption problems, and they may have like IBS or things like that, and trying to find other routes to try to, like, because IBS, there's the whole, and this is a whole different topic, but there's this whole gut and brain. The microbiome is becoming a very interesting and very important area that we need to talk about. And so looking at diet and probiotics and other ways to make sure, because inflammation, if there's inflammation in the gut, that could actually open up a space that could lead to sensitivities or even infiltration into the CNS or brain. And actually there's some data to support that, maybe some suggestion, we don't know for sure, but for multiple sclerosis, there's the brain gut hypothesis around maybe triggering that, and also for schizophrenia as well. So I'm thinking that like gluten allergies are big, and they can actually open up that blood-brain barrier to toxins or immunological insult. And so diet, I think you're bringing up a really, really important point. Dr. Erickson, do you want to say anything more about that? I don't want to take too much time.
Yeah, just real quick. I really appreciate with your comments on that. The other is kind of alluded to in earlier in the talk, and that is the savvy caregiver and family member. In other words, knowing your individual, being able to maybe redirect. And in other words, they might be having a moment that a person might be having a moment that the meds they just don't want to take it. Real honestly, most meds don't have to be given right away. And so there's usually a window of time that they can be given. So with that, knowing how to redirect individual, get them interested in their hobby or some other thing that they like, and then come back to it and try the medicine again. That is from the focus groups and working with caregivers, that's probably one of the number one ways to try to do that. So absolutely,
Thank
but it
you. That's really
happens.
helpful.
Yeah. All right. I think we're about out of time. Are any other last questions? Well, I really truly appreciate the Mark and Jamila for being here today. I really thank you so much for your time and expertise to help inform the clinicians and community members that will be viewing this video. So again, thank you so much. And to the center for having us.
Yeah, no problem. Thanks for having me.
Yeah, same. Thank you, Dr. Erickson, and nice meeting you, Lauren, as well. So good luck to everyone, and thank you again.
Nice meeting you too. Thanks for having this.
Yeah.